I'm very excited to have our speakers with us today, and even more excited to be back in person. There is rumor that we'll be able to relax some of the space restrictions in non-clinical areas in the coming weeks, and I think that trying to get something back to what we used to, what we call the pre-pandemic normal, is welcome, and definitely from an education perspective, because these events are very fun, and it's nice to get together over some pizza and learn new stuff. So if you need people that are online, we've got lots of people watching this via Teams. If you have a question, enter it in the chat, and after we're done, we would ask our experts your questions. And for those who couldn't stay for the whole presentation, or for colleagues who couldn't make it, this will be archived on the medical education website, and we will send you the link. And after, I'm going to give you a QR code for a survey to help us make rounds even better. Okay, so without further ado, I'd like to welcome our guests today. And today's talk is on COVID. Today's talk is on a little bit on all of the respiratory viruses. We're going to touch on influenza and RSV, but really it's mostly, okay, what's the state of COVID? Where are we right now? And there's no better people to ask this question to than Dr. Colin Lee and Dr. Amir Khosrovaneh. Dr. Colin Lee is a Royal College certified public health and preventive medicine specialist who's been with the Simcoe Muskoka District Health Unit since 2003. He is currently an associate medical officer of health, whose primary responsibilities are in the clinical services program, including communicable disease control, vaccine preventable diseases, and sexual health. Dr. Amir Khosrovaneh, of course, most people know Amir from the hospital. He's our ID expert here, and he's a Royal College certified in internal medicine and infectious diseases since 2007. He's also an infectious disease specialist and medical director of IPAC. He specializes in the prevention and actual treatment of different communicable or infectious diseases. So let's get a round of applause for our two guests. Okay, I'm going to start off. This is a very informal kind of process where we have discussion. If you have any questions, save them at the end, and they'll be happy to answer. So let's start off. What's the current status of COVID-19 burden in Canada, Ontario, or in the area? And how do we know that if no one's testing like they used to?
Yeah, it's true that there is a lot less testing occurring, as you know, for the PCR testing. There's eligibility criteria like healthcare workers, long-term care homes, et cetera. And there's just less testing being done at rapid tests. So it is difficult to know if you just look at how many cases are being reported. At the health unit, if you haven't noticed, we are providing a community risk level measure. If you come to our website, it's classified at 4 levels: lower, moderate, high, and very high. And we're currently at moderate. We've been at moderate for a number of months now. And then before that, we were at high when we started last year. And it's trending downwards. And this measure tries to take into account a more holistic view of COVID, versus before when we had no vaccines, we had no medicines, we had no immunity. So it looks at wastewater levels, cases, hospitalizations, as well as outbreaks and percent positivity tests. So, with that, we're at moderate, and it means we're not out of the woods, so to speak. It's still there. But lower is what we're aiming for. And our percent positivity test rate over the winter has been quite high still. Right now we're at 10%. It was as high as 20%. So for people presenting for PCR testing with symptoms, you're still getting 1 in 10. Pretty darn high in terms of testing. And I guess what we're seeing that as we get newer strains, they are sort of more transmissible. But if we look at where we are now, winter of 2022, 2023 versus the terrible winter of 2021 to 2022 when Omicron first arrived, there is a lot less morbidity or less burden. There is, and this is really largely because we just have much more pre-existing immunity. A number of us here have had COVID, myself included. A number of us here are up to date with our immunizations. And so even though the new variants can get past that protection and are more transmissible, what we're seeing is that for the younger populations, there's less morbidity. However, I think what is perhaps lost in the media, in people's just approach to COVID, because we're sick of it, is that for the older population, we're still seeing a very significant morbidity. Just to give you an example, in Simcoe, Muskoka, in January, we had 30 deaths from COVID, 21 in February. This month is lower. And what we're seeing is predictably those who are 65 and older who are dying, with the vast majority over 80 years of age. So it's still quite significant if you are in the age group or you have loved ones in that age group. On the flip side, we know if you're 80 and over, that's pretty darn good life expectancy already. And that you have lots of you may have medical conditions. You may have, as you get older, you're going to get a less robust immune response to previous infections and vaccines. But we are still seeing, lots of deaths there. At least from my point of view, still an unacceptably high. I mean, just to give you an idea, for influenza this year, I think at least reportedly we have had 2 or 3 deaths. It's probably more than that, but it's still quite different from what we're used to seeing in other sort of respiratory infections. So, in order to try to decrease that, we still have to at least, for that population, really concentrate on their immunity through immunization, and then also early access to medications like Paxlovid. So for March, it's looking brighter, although not so bright outside today, but the temperatures are warming. The cases are coming down. The outbreaks coming down. So, I think it's looking good for now.
Good. And what's the, you spoke about Omicron, and at one point everyone knew the variants. What's the strain worse than ever? What's the current dominant strain?
Yeah, it's got its popular name, which is I think previously known as Kraken, but it's the XBB 1.5. It is following the same trend it has been for previous emerging dominant strains. So they become more dominant because there's more transmissible than the other strains. We are seeing lots of cases, like I mentioned, over the winter. Percent positivity rate was upwards of 20 at times. Now it's still at 10. But we are not seeing an increased mortality or morbidity from it. We seem to be seeing less morbidity, certainly in the younger population. But again, for the older, we're still seeing what at this time seems to be a constant, number of hospitalizations and deaths. So no indication that it's more severe.
Okay, thanks, Colin. And Amir, at RVH, how's the burden here in terms of both, symptomatic and the incidence of positive cases, which of course have a lot of effect on how we, admit patients and where they go?
Yeah, as Colin mentioned, we see lots of COVID in the community. I can tell you for the last few months, the percentage of positive COVID patients admitted to the medical floors was around positive COVID tests was around 10 to 12% of the population patient. Of this 10%, I would say 67% were true COVID and 30% incidental COVID. To the lower risk groups, such as surgical floor or OBGYN, the positivity rate was around 2-3% of the total population. About 20%, about half of them were incidental COVID and half of them. And again, I can't mention the mortality is mostly the elderly. We still see mortality about less than 5% population. But if you remember, first wave Delta wave last 2 years ago, the mortality for the elderly was more than 35%, and everybody was ending up in the ICU. Right now, mortality is still high because we have lots of cases, but dropped to 5% of the population there. And we are still seeing outbreak every month or so because of the number of the cases and the modification of our health such as visitor policy, lots of transmissions from the visitors to the patient. But then you see the risk you have to accept. And for the staff, for the last few months, we continue to see a steady level of maybe 20 staff of the COVID per
20 staff per week.
Yeah, something like that.
And that's a huge effect. That's already our staffing isn't great. So as much as it's nice to go back to these normal settings of no masks, we do have to be cognizant that it's still out there and still can affect us and our ability to go to work and care for our patients. So, okay, and yeah, I agree that from the IC perspective, we've had the occasional COVID in the last couple months, but really not that many. Most of them have been had some immunosuppressive disease or condition that is predisposed them. Unlike, as you said, 2019, 2021, where very healthy, otherwise well people were getting it. So it's definitely become, at least in the ICU perspective, more of an opportunistic infection in terms of severity. Okay, now, Colin, I'm going to ask you this is the question I've been asked. Has the pandemic now become endemic? And what's the difference?
Yeah, so I don't think we can definitively say that, that at this time that it's an endemic, but it's acting that way right now. What has been happening really is you're seeing a steady level of COVID activity. We haven't seen a big wave or spike since the fall, really. And if it stays like that, that is really the definition of endemic, where it is there all the time. I certainly, it's nice to have lower levels. I'm happy with that. But I really would prefer it to become more like influenza, where it's a seasonal epidemic, late fall to late winter. That way it's more predictable, it's more manageable. We can time our vaccines better. But if it's endemic, certainly it's not great because we have to worry about it every day of the year. And it makes it difficult to time immunization interventions. So, but it is acting endemic for sure.
Do you think it'll eventually get to that seasonal?
Yeah, I mean, I think, our experience with respiratory pandemics have really been with influenza. And each time with each influenza pandemic, that's what has happened. Of course, this is not influenza and it's COVID-19, so we don't really know. But, hopefully they've talked to influenza viruses and said, hey, this is the way to go. Better for you. And they will act like that. And cross our fingers that maybe next winter is when that will start.
Perfect. Amir, what are the current treatment recommendations now with outpatients, inpatients, and critically ill patients? Those kind of three populations.
So, as other aspects of COVID, the outpatient treatment for COVID continues to evolve. The main treatment for COVID is Simcoe, because it's oral, it's easy to give to the patient, and it's available. The best data for Paxlovid that's available is very effective for immunocompromised patient, elderly patient, or patient with multiple risk factors. The study shows that to prevent one hospitalization in these patients, we have to treat 18 patients. So if you treat 18 outpatients, we can prevent one hospitalization in these high-risk patients. But the data for a low-risk patient, for vaccinated patient or younger patient is not very validated. We don't have too much data, but it looks like it's not very effective in this patient population. Regardless, the Ministry of Health updated their recommendation for Paxlovid, I think, for late December 2022. They included the loss of the patient population, but it's not totally evidence-based. And some of the group that they recommended, based on the current data that is available, it's not very good. But more data is coming to that shows the effect of the Paxlovid on low-risk patient and vaccinated patient, hopefully in the next few weeks. And it should guide us for the optimizing the management for the outpatient. The other treatment that's available for outpatient is taking for unvaccinated and high-risk patients, 3 days course of the IV remdesivir, which is challenging because it's IV, you have to be 3 days in a row. It's not really bad. So it's still the best options. For the inpatient population, most of the treatment remains about the same compared to last year. But the most important for the inpatient population, before going to the treatment, I just want to talk a little about the diagnosis. So because when we see we are getting a patient with positive COVID test, there is some challenges in that because we don't know is it true positive or false positive or false positive. For lots of people, they are positive, the COVID test and the PCR test can be positive for months. So when we are attending a patient, it's important to find out the previous history if the patient was recently at COVID or not, especially, for example, from nursing home. They can have a rapid test a few weeks ago, positive, nothing, nowhere is documented. They cannot find the quarantine care, they cannot find the HR, and patient usually from nursing home not able to give us any history. So if we see a positive COVID test from nursing home or elderly people, we cannot get histories of COVID, from the family or from nursing home, they have a recent COVID rapid test or not, because it happens to treatment. The other thing for the COVID test, if you see a patient that history is questionable and has a COVID test with a high CT value more than 35, which will have been reported. So you have to think twice. Is it either old infection or is it new infection? So we don't have to jump on the treatment right. We have to clarify the status of the patient. So back to the treatment now. If the patient we admit the patient to the hospital, and the patient is stable, is incidental, and does not require any oxygenation. Overall, there is no treatment recommendations to continue support care. But if the patient is high risk and unvaccinated, we can again give a short course of the remdesivir. Some data should be against the further complication. This is for non-oxygen. If the patient does not require oxygen as monitoring. If the patient requires a low level of oxygenation, 1 to 2 liter, the treatment remains about the same, remdesivir and dexamethasone, dexamethasone. If the patient is stable, it's only 1 to 2 liter, and in the first 10 days, maybe we can put dexamethasone to see what happens, because as you know, dexamethasone has a lot of complications, especially for the elderly patient with the immune system. We can watch for a day or so. If the patient is stable, getting better, we can just go with the remdesivir. In this patient population, if after a few days oxygen requirement increase and patient does not respond to the treatment, then we can move to the total of the interleukin 62 or about the criteria for that. If the patient after 2 days of dexamethasone treatment, they require higher oxygen requirement. They require, for example, if there are 2 liter guidelines or 9 liter maximum, they require high flow oxygen. And they have a CR more than 75. Recommendation given about this as a last year, we can go again at the Tosky and participate. For the next level of the patient who require the high level of photo and bypass, recommendations giving the dexamethasone and the Tosky or Barton. There is no preference with the Tosky or Barton, both of them are available. In this patient population, the role of remdesivir is not clear, but if the patient is already on remdesivir, it's better to continue to finish the course of the treatment. And for the last group of the patients, the single patient, as with the already patients intubated, there is no role for remdesivir. The remdesivir, the treatment is for dexamethasone and the interleukin 6 variants such as Tosky or Bartis.
Perfect. So thank you very much. That's very comprehensive. It shows the spectrum as you escalate up. And so essentially you see the people on RESP who are on OptiFlow or get consulted at ICU. Generally, that's the people we're thinking about giving them interleukin 6 too. You mentioned the CT threshold, the cycle threshold for diagnoses. So just a quick explanation. So the cycle threshold is the number of cycles of PCR it takes for the test to become positive. Theoretically, the higher number of cycles means there's a smaller sample. A lot of variables in that depends on how good the sample is, but also depends on your viral load as to how quickly that becomes positive. Is the cycle threshold made available in the results section only when it's kind of borderline high, or is it for all positive results?
So lab report is more than 35, so the cutoff is 35. If it's more than 35, then could be able to patient of false positive.
So if you see that, maybe
The lab report.
yeah, exactly. And so I probably have a question for our IPAC practitioners to kind of help better understand whether this is an acute infection. I'm not sure, but as Dr. Khosrovaneh said, history in those ones is key. All right, thanks.
If it is a heavy infection, can be 24 to 48 hours.
Excellent. Okay. Now, similar infections in the community right now. there's been lots of gastro. And initially, when COVID first came out, every symptom of every disease could be COVID, including gastrointestinal symptoms. So I get asked all the time, listen, my kid's got gastro. Is this good to see COVID?
I think at this time it's unlikely. I mean, there's a few things. With the newer variants, it's becoming more like the traditional cold, upper respiratory type symptoms. And because of the increased interactions that we're having this winter, norovirus is back where it belongs. Unfortunately, that's what happens in winter and daycares and long-term care homes. And so, yeah, we've had quite a bit of norovirus. So it's more likely just good old noro or rotavirus.
It's amazing how quickly we forget all the viruses we all got and our kids get every year. They're back.
And we have already 2 outbreaks for outbreak so far this year.
I think we're in one right now. Yeah. So good hand washing, still important. Funny how that goes. Excellent. Okay. Colin, what are the current vaccination guidelines? And we can give you 3 examples because at this point, some people are just a little bit lost. There's still the unvaccinated, the people who just were diehards, and there's still people who got 2 shots, but then we're like, that's maybe enough. And then there's the people who are probably at 4 more or have a booster after with a bivalent booster. What would the recommendations would you give to those 3 patient populations?
Yeah, I mean, at this time, for everyone, it's fairly simple if you're in the younger population and sort of the non-severely immunocompromised. Basically, you get your primary series, which is usually 2 shots, or 3 if you were severely immunocompromised, and then at least 1 booster. That's one thing. Second of all, is to make sure that you had the bivalent booster from September 1st of last year onwards. So those are the 2 sort of things that you want to do. Primary series and at least 1 booster, and of those boosters, 1 of them should be the bivalent from September 1st onwards. Now, people will say, well, I haven't got it because I got infected in January before I was due. What I would say is that you still want to get the bivalent booster sort of 6 months out from the last infection. So that's generally what it is for all comers. The National Advisory Committee for Immunization just came up with some recommendations for spring moving forwards. And it's a much more targeted approach. What they've said is for those who are 80 and over, for those who are 65 and to 79, who don't think they ever got an infection, then long-term care homes, and then 18 and over with moderate or severe medical conditions. For those, they recommend every 6 month booster at this time. So if you got your bivalent booster in October and you haven't got infected, then you should be thinking about getting 1 6 months onwards. Now, Ontario hasn't come up with their stance at this time. I suspect they will come out in 2 weeks' time, and one would expect it's not going to be very different. So for everyone, really, most of you are immunized, and really what you need to do is just make sure, ask yourself, did you get your booster September 1st onwards? And if you haven't, and it's your time because 6 months since your last infection or last shot, then go for it.
Perfect. That's good. That's a question I get a lot. I didn't know the answer to it. Okay, Colin, what about influenza and RSV? Are they still, they seem to be for a while, especially the pediatric populations, overwhelming the ped centers. Are they still active in the community?
So the good news with influenza is that it's really, really at its tail end of that influenza A H strain. I think we were very worried in September when it came and RSV came and COVID was still around, just by sheer number of infections. H3, influenza A H3 is usually one that causes us a lot of grief. But this year, even though there was lots of cases, we had less outbreaks, looked like less mortality. And I think it's largely due to the fact that our vaccine this year matched very well. And so to answer your question, influenza A is on the outs. Having said that, occasionally there will be an influenza B second wave in late winter, early spring. But that's remains to be seen. And RSV, as you know, it was really in the early fall, really in the pediatric population, but it's petered out as well.
Okay.
As seasonal.
That's good news. The pediatric centers are really struggling in the fall for sure. And getting back, we kind of talked about how bad of flu season. What was the burden here for flu and RSV and RVH?
Normally, for the last few years after the pandemic, we had for the last 2 winter, we had 0 admission. So, but this year, so far, we have 7 people, 7, 8 have not admitted with influenza and 50 with RSV. The pediatric population, we have 71 with the RSV and 20 patients with the influenza. And 3 of them have mixed infection. With regards regards to our vaccination rate for the staff, unfortunately, the vaccination rate for the staff this year was very low, for as around 25 to 6% for the staff and the physicians, maybe because of the vaccination fatigue. But as Colin mentioned, because there was a good match for the vaccine and because of the vaccine masking policy, fortunately, we didn't have any so far often. I will section of the hospital for the influenza.
Was there how was the uptake for flu vaccine in the community?
I don't think it was any, it was probably a little bit lower. It's hard to know at this time, but it's usually hovers at about 50 or less. So I don't know. We'll have to look at it retrospectively.
Do you worry about the vaccination fatigue extending, or people being like, well, I survived COVID, like I don't need a flu vaccine?
Yeah, no, it is true. I mean, like it's, I think we just don't like to do lots of things repeatedly, right? And, I think what we're hoping the next number of years is that there will be an all-in-one shot. It's a lot of money to be made there to have your COVID vaccine and your flu vaccine, and then potentially the RSV vaccine at some point in time all in one. So if the timing is right, then that can all be done once a year.
And so the current recommendation would be for influenza in the fall still, that hasn't changed in terms of the schedule and everything?
Yeah, the flu vaccine's usually sort of late October, early November. Get it early, that's the biggest bang for your buck, as opposed to you start thinking about it now. It's really not it's not useful anymore this year. It's almost at the end, unless you're traveling somewhere. I think this fall, if I had to predict, it'll be, get your flu shot, get your COVID shot.
Is there an RSV vaccine?
I think they're still developing it, but I don't think it's that close.
The only thing if you are a patient, especially saying in the hospital as a healthy or long term, if the vaccine is not updated, it's still going to be.
Yeah, because they're certainly higher risk.
So your influenza vaccine or your COVID vaccine. Okay, and what about treatment options for influenza RSV? What are recommendations for those?
Yeah, RSV is mostly supporting them. Not much we can do. Only certain patient populations, such as high risk vulnerable transplant patients or lung transplant. We can give rivalry, some studies for some kids, but it's not a easy evaluated rivalry. So it's mostly supporting here. For influenza, same thing. There is no change in the recommendation. It's based on most of the data that's from 2009, 2010. Influenza pandemic that you had at that time. So for the outpatient, if you have outpatient at the time, who is circulating in community and the patient is high risk, you can start the patient on the Tamiflu. And initially, the recommendation was to start the first 48 hours, but if the patient is high risk, is the kind of recommendation is beyond 48 hours of symptoms, still some benefit to start the comment. For the inpatient, the recommendation is to treat all the patient probably the Tamiflu, regardless of the duration of the symptoms, because there are some data that shows decreased complication rate in the inpatient population.
All right, so that's it for the questions I had for our expert speakers. I want to open up to questions from the floor and questions online. Any questions in the audience for Dr. Khosrovaneh or Dr. Lee? Don't be shy. Okay, John.
With respect to the vaccines, right? That it's fallen out of most people's point. Somebody wants a vaccine now, where are they getting their vaccines? Is it the same places?
Yeah, I mean, thankfully, the pharmacies have done a great job of providing an outlet to get their vaccine. So I think for most people, pharmacies are still their best bet because there's always one around the corner. They're open 5, 6, 7 days of the week. They can always call the health unit. We have sort of pop-up clinics, but those are the two spots I would imagine.
And I think Sperling Clinic is about to give its last shot.
Yeah.
Thursday of next week. And I was talking to Dr. Gardner this morning, and he said I think there were 70,000 vaccinations given to that clinic.
Yeah, it's done a great job. Honestly, it has served so many people. Especially in the early days when there wasn't that much vaccine and not many places to go to.
So a major collaborative effort between the public health and RVH, and I know some people in this room worked at that clinic, and so that's a big accomplishment for our institution. Yeah, Danielle.
About testing, because Sperling Clinic does the testing, is that only for healthcare workers or it only symptomatic or is that going to be testing?
Yeah, I don't know if that went to us, but hopefully what takes. After March 31st, they tell us, but RVH is going to extend it for that for cleaning for a few months, but testing.
Good question. Any other questions in the room for Dr. Khosrovaneh, Dr. Lee? Mitch online, are there any questions from the audience? Okay. Well, I think the summarize some of what I've heard is that there's COVID still here. And unfortunately it's getting better, but it's not gone. So we still have to have diligence with our patients and with ourselves. Luckily influenza and RSV are on the outs. There's still hope. I mean, obviously, we hope this becomes a seasonal thing. We just have one shot for everything. Obviously, want to thank everyone in public health, Amir's team in IPAC, and all of you in the hospital because the last 3 years have sucked, and it's brighter days ahead. I also want to thank Mitch Green, who helps organize all these rounds and sets everything up, and Amy Dempster, who coordinates all the AV. So thank you for their work, and of course, thank you to our two wonderful speakers. Thanks so much. Can scan this in your way out to give us feedback on rounds. We'd love to hear them. And we'll be back in April with hematology, Sheila Saunders on deep vein thrombosis. Thanks very much. Thanks. Appreciate it.